Hi, I'm Betsy Nicoletti. Thanks for joining me today to hear about risk diagnosis coding for common medical conditions. I really appreciate you making the time today. So, did you ever wish that you could communicate to the people who are making healthcare decisions just how sick your patients are and how complicated they are while you're caring for them? Well, you're not alone in that. I'm going to go back to the late 80s. I was working with a general surgeon, and Dr. Fabricant had a card that he would keep in his pockets, and every day of the month had a card. And he would write down what he had done: hospital visit, surgery, ED visit. But he didn't just write down what he had done, he wrote the diagnosis codes: small bowel obstruction, hernia. And then he would add hypertension, diabetes. And I said to him, Dr. Fabricant, we get paid the same amount if I put down one diagnosis code or four, because I was a lazy diagnosis coder and I didn't want to look up the other three codes. And of course, back then, that's how long ago it was, we could only use four diagnosis codes. Dr. Fabricant said to me, Betsy, I want the insurance company to know just how sick this patient is. So last week when we talked about level of service, I did say that if you bill all twos and threes, that tells part of the story to the payer about how sick your population is. But even more important is the diagnosis codes that you use on the claim form. And I know you'll say to me, as we talked about last week, we're an FQHC, we get paid a PPS rate. What does it matter how many diagnosis codes I put down or that the payer knows how sick the patient is? Well, there are some contracts where the rate that you're paid on a monthly basis is paid based on the HCC codes. And it's important to explain, it normalizes the costs, outcomes, and quality measures. So if you have a population of patients who aren't that sick, I coded for all of them when I was a lazy diagnosis coder, and then you have a population of patients who have a higher disease burden, and the costs are the same, the outcomes are the same, the quality measures are the same. People will look at these patients who aren't too sick and say, gosh, um, uh, why are their costs and quality measures and outcomes the same as this higher acuity group of patients? So we've scheduled 2 sessions on risk-based diagnosis coding. This one, where we talk about the overview of it and how it works. I promise not too much detail, and common medical conditions. And then next week, we'll talk about behavioral health conditions, substance abuse, depression, and other major psychiatric disorders, status codes, I put that for next week, and social determinants of health. So we'll hear about all of that next week. So I often say that medical necessity is like beauty. It is in the eye of the beholder. But of course, your diagnosis code establishes the medical necessity for the service. And it doesn't just tell the payer what the patient has, but some diagnosis coding talks about severity or stage, whether the condition is due to something or has another complication or a manifestation. On the individual claim, the diagnosis code tells the payer just that for this patient. But if you think about all of your patients and all of the diagnosis codes that you assign for them, the acuity of your whole panel of patients is communicated to the payer based on what you choose at the end of the encounter. So what is risk adjustment? Risk adjustment is a system that was developed by Medicare and private payers to estimate future costs. So the model that we're going to talk about today, hierarchical condition categories, HCCs, was developed by Medicare to estimate how much it would cost Medicare Advantage organizations to care for the patient next year. So that was the first use of them. It was it developed a risk-adjusted factor for certain diagnosis codes, and then a patient who has a lot of those conditions has a risk-adjusted factor that goes along with them. How is this calculated? It's two ways. First, demographics. Of course, we can't do anything about demographics. And the second is diagnoses. So there are different factors or coefficients for patients based on their age and gender, whether they're living at home or in an institution, if they are dually eligible for Medicare and Medicaid, so different coefficients for those populations. And then diagnosis risk adjustment. Risk adjustment is based on the diagnoses that are submitted on inpatient claims, outpatient hospital claims, and physician claims, and certain other professional services, social worker, physical therapist, but not based on diagnostic testing, not on the diagnosis codes that are submitted on a lab or an X-ray. And it's codes that are submitted in a calendar year. So I'm going to come back to that, how the slate is wiped clean at the beginning of every year and starts again fresh in January. I'm going to move on and talk a little bit about ICD-10 guidelines. Before I do this, I do just want to thank Ms. Garcia and Ms. Clemens. They provided me with a lot of input and help. I know they're both on today, so I want to thank them personally for the help that they gave me when I was putting together this presentation. It just helped me understand your organization. All right. Every clinician loves diagnosis rules. We're going to use the ICD-10 code that describes the patient diagnosis, symptom, complaint, or condition. In the outpatient setting, in the medical practice setting, we don't code suspected, possible, probable, or rule out. Now, of course, you see a patient and you make a clinical diagnosis. Patient has, by history and exam, has pneumonia. You don't need a diagnostic test to confirm that, and you write pneumonia in the encounter form. You select it. But sometimes the patient, you're pretty sure what the patient has, or you suspect that the patient, based on the history, bleeding and cramping, that the patient has a uterine fibroid. But what you're writing in your assessment is rule out uterine fibroid, and you're scheduling a diagnostic test. In that case, we would use the symptoms, the bleeding, dysfunctional bleeding, and pain, rather than the suspected diagnosis. We use the ICD-10 code that's chiefly responsible for the item or service provided. So far, so good. Assign the code to the highest level of specificity. If they wanted us to be specific, why did they give us 70,000 diagnosis codes? I'd like to know. We code a chronic condition as often as it is treated. And this guideline is the chief guideline that we use when we're thinking about HCC coding. And it's a guideline that when we look back at the Medicare documents for risk-based diagnosis coding, that they emphasize as well. Code all documented conditions which coexist at the time of the visit that require or affect patient care or treatment. Now, if you remember last week, I said, if you don't address the problem, if you say chronic kidney disease managed by the nephrologist, we don't use that condition to select your level of E&M service. And at the risk of making all of the clinicians annoyed, there are slightly different rules for selecting our level of service and for using diagnosis coding. So here, and we're going to look at some examples, if the patient's coexisting underlying condition affects the care of your acute problem today, then based on this ICD-10 guideline and based on the CMS documents, we're going to use it in the encounter form. We're going to select it in the encounter, and that sends it off to on the claim form. We don't code conditions which no longer exist. That sounds very intuitive. Why do we even have to say it? But next week, we'll look at some codes where we see that error in coding conditions that are really past medical history. So this is the important thing, and I'm going to repeat this a few times. We're going to code all of these conditions every year. We're going to code chronic conditions, and if there is causality or complications, we're going to code that, with or without, due to or secondary to. We're going to document the status of those conditions and a treatment plan. And then there are a few status codes that risk adjust and a few important social determinants of health codes that we'll talk about next week. I promise I'm going to be brief about this. When we're calculating HCC scores, we're not doing it with a pen and a pencil or in a spreadsheet. There are software programs that do that. Your organization may calculate HCC scores based on the conditions that you were submitting. But let's say the patient was in the hospital for an acute or chronic problem, or maybe for a trauma. The conditions that are documented and coded in the hospital count towards the patient's scores. And you may not have that in your internal calculation unless you get a file from the insurance company. So the risk score is with the patient. Wherever the patient goes to be seen, cardiology or an outpatient department or your practice, the risk score is a combination, is an addition of all of the conditions that are coded in these locations over the course of a calendar year. Just briefly with some of these rules, the most serious manifestation is credited. So if there are two related conditions in the same category, only the most serious is counted. Sometimes a patient may have two malignant neoplasms, only the most serious is counted. Two conditions in the same group are only counted once. So if the patient has diabetes with retinopathy and diabetes with hyperglycemia, those both are in the same group and they're only counted once. Now, that doesn't mean you don't want to report them more than once. I'm just telling you, we don't keep adding up the score. Unrelated conditions in different categories are both counted, and that score is additive. So a patient with COPD and chronic kidney disease, those are unrelated, those get added together. There's some exceptions, obviously, but you don't have to worry about those. Now, here's a citation from the CMS document, and I'm going to translate it in the next slide. So CMS says there are certain serious, significant, ongoing conditions, and they've listed some of those at the top of this slide. They say that the management of these diseases, of course, it has a potential for exacerbation, but it is likely that particularly if the patient is experiencing other acute conditions. And it's likely that these diagnoses would be part of a general overview of the patient's health when treating conditions for all but the most minor of medical encounters. So here's the plain English translation. Patients have serious, significant, ongoing problems that have a potential for exacerbation, and these are often considered and need to be considered if the patient has an acute problem. CMS says they are likely addressed at annual exams, and we're treating for all but the most minor of medical encounters. So, of course, we count on you to document those in the assessment, but CMS expects that for patients with these chronic conditions, if you're seeing them for an acute problem, if the chronic conditions affects the treatment for the acute problem, that you'll add it to the claim form. So what are we going to add to the claim form, or what are you going to select in the encounter? We don't pluck a condition out of the past medical history, out of the problem list, or out of the current list. So no coder is going to go up to your problem list and say, oh, look, here's a condition that has a risk-adjusted score. We haven't reported it lately. I'm going to pull it out. No, of course, we wouldn't do that. We are coding conditions, though, from the assessment and from anywhere else in the note that you've documented. So if you write in the HPI something about that patient's condition, or if in the exam there's an abnormal finding, or more typically, we would see it in the assessment and the plan. We're allowed to use that anywhere we can see that you evaluated that patient for that condition today. Again, we aren't allowed to just take it out of past medical history. Documenting a treatment plan shows evidence of the assessment, of the management, or how the condition was treated. Now, we don't have to write War and Peace. It doesn't have to be a long treatment plan. Some of the examples that we see and that we're going to see can be brief, but what we're going to see is that you've evaluated the condition, we have the status of it, and then a treatment plan that goes with it. Now, the American Academy of Family Practice recommends that you report the patient's chronic conditions at a preventive medicine service and wellness visit or at the first visit of the year. Now, I know you don't love the wellness visits. No one loves the wellness visits. Well, I do. No one loves the wellness visits, but the AAFP suggests that if you're doing them, if you're personally doing the wellness visit on your patient, we know that patients don't, when they come in for their wellness visit, they don't not tell you about their chronic problems. So if you're talking to the patient about their chronic problems at the wellness visit, you're going to add those chronic problems to the assessment, and it'll go out on the claim form. If you have other clinicians who are only doing the wellness visits because you don't have time in your schedule or you don't like to do them, they may be less likely to be addressing the patient's chronic problems at the wellness visit. All right, so here's an example from Optum. Patient comes in for their annual exam. You document the vaccines, the screenings you ordered, all the advice you gave them, refuses the Pneumovax, doesn't want to get the Cologuard, but you document the annual exam parts, and then the other underlying conditions. COPD, stable, followed by pulmonary. Diabetes, stable on metformin, getting a lab test. Osteoarthritis, continue the anti-inflammatories. So we want to see the condition, the status, and the plan, but we don't need War and Peace. We report chronic conditions annually. The slate is wiped clean January 1st. I say the insurance company has a short-term memory problem, but that's not the case. It is a Medicare rule that if we're calculating risk scores, that we can only use scores documented and submitted in this calendar year. So of course, this is retrospective. So last year's scores set this year's rate, but the insurance company that is setting these rates isn't going to go back 2 or 3 years. Oh, you reported chronic kidney disease in 2019, must still have it in 2020 and 2021. No, these conditions need to be reported by someone who's assessing the patient every calendar year. For chronic conditions with a manifestation or a complication, or if the code description has a stage or severity, we're going to really use those codes. And even the lazy diagnosis coders amongst us are going to avoid the unspecified codes for chronic conditions. There are only a few status codes that risk adjust. We'll look at those next week. And we're going to add the social determinants of health, again, once in a calendar year. So here are some examples that I put together of patients' chronic conditions affecting the treatment of another acute or chronic condition. So you have a patient who has hypertension, is not in good control, and you consider the patient's kidney disease prior to changing their hypertension medicine. And you say, I'm not going to give them this class of drugs because. So it would be correct to add both the hypertension and the chronic kidney disease. Now, we would expect to see that comment, and that comment could be up in the HPI, or it could be down in the assessment and the plan. There's no requirement for where that is. Typically, we'd see that comment in the assessment and the plan, but it could be somewhere else. And if some clinicians write a comment after the condition for every single condition. So if there are 4 conditions listed, there are 4 separate comments. And some clinicians make one bigger paragraph in the comment under the first condition. The guidelines don't tell us you have to do it one way or you have to do it the other. So if you've made the comment under the hypertension about the kidney disease, you can still add the kidney disease to the claim form, to the encounter. You're seeing a patient who's got terrible itching from poison sumac, and the patient has diabetes, and you say, I'm not going to give him prednisone because he has diabetes, and the last time he had prednisone, his blood sugars were such and such. Patient has migraines, and you're thinking about their asthma in selecting the treatment, and you note that because of the patient's asthma or the medication the patient takes for asthma, X, Y, and Z. So when you're treating an acute or chronic problem, but another condition affects that care, then we are going to add that other condition to the encounter, as long as you've documented something about it in the comment. And remember what the CMS guidelines say. They expect that these serious chronic conditions likely affect the care, except for all but the most minor conditions. So that's what Medicare tells us. I know this is a repeat. We're going to report these annually. We're going to be very specific about chronic conditions which have manifestations or complications, or where the code selection includes severity or stage. Now, there's one more HCC factor that I'd like to talk about. When certain conditions occur together, the risk increases. So instead of it just being additive, where I have a risk-adjusted factor, where I have a RAF for 2 conditions, instead of just adding those together, there's a bump. So the whole is more than the sum of the parts. Patient with an immune disorder and cancer, and look at congestive heart failure. When congestive heart failure occurs with any of those 4 conditions, it doesn't just add together the risk-adjusted factors. For those 2 conditions, it gets an increased bump. COPD and chronic renal failure, and substance use disorders and psychiatric conditions, which we'll talk about next week. Here is another citation, and we're going to have a translation soon. What this basically says is, if there are codes that have the words within them in either the alphabetic index or in the tabular list, we're allowed to assume that they're related, unless the clinician specifically says they're not. So here's an example from diabetes. Patient, if I look in the index for diabetes, and then I see the word with, and I know you're not looking at the index, this is a coding thing. If it says with chronic kidney disease, I can assume that if you have diabetes in the encounter and you have chronic kidney disease, that they're related. And I can choose, instead of choosing E11.9, I can choose chronic kidney disease, E11.22, diabetes with chronic kidney disease. Then we'd add a code for the chronic kidney disease, of course. Now, I know you're doing this work yourself. No one is going behind you and choosing these. And I know that it can be difficult in IMO to find these codes. And in the long run, if we can get some of our problem lists updated, once the code is in the problem list, it's easier to use it than it is to find it and put it in. The other thing I want to say about IMO is something I know you know, is that initially IMO thought it would be helpful if they used a lot of synonyms. So instead of just putting down diabetes type 2 without complications for E11.9, they used, words like controlled, they used a lot of synonyms for it. And when you look in IMO, if you see that the code itself is the same, even though we've got 5 synonyms for it, don't take any time to find the exact right synonym. When we submit that to the insurance company, if all 5 of those synonyms say E11.9, all the insurance company sees is E11.9. It's, for me, it's the perfect example of unintended consequences making life more difficult when the purpose was to make it easier. All right, these are, it isn't just type 2, any type diabetes, type 1, or diabetes from medications. There are 3 categories. Diabetes without complications, and there's that risk score that I've been talking about, that RAF. So without complications, 0.105, and with either chronic or acute complications, the risk score triples. Sometimes we look at an encounter and we see E11.9, diabetes without complications, and we see E11.65, diabetes with hyperglycemia. And of course, from a coding perspective, we're saying, well, if they have complications, we shouldn't use the E11.9. I completely understand how this happens. Sometimes the prescription renewal is under the E11.9 and it's just easier and quicker. Sometimes there are comments or notes that you can get to related to that other diagnosis in the problem list. As much as possible as we go forward, if we can remove conditions that aren't accurate anymore and replace them with accurate conditions, it helps. So we're assuming a causal relationship when the word is with in it. Diabetes with chronic kidney disease, diabetes with peripheral neuropathy. If there's a complication, we prefer to use that code and not the E11.9. And I did look at your Arcadia report, and it looks to me like I might be preaching to the choir here, that many of you are using these more specific codes. Here are just some of them. For diabetes with hyperlipidemia, we can use E11.69. Oh boy, I know that's going to be hard to find. Who's going to search diabetes with other specified complication, right? But hyperlipidemia does not risk adjust. So if you have a patient that doesn't have other diabetic complications, but they do have hyperlipidemia, this code triples the risk score. There are certain times, if you have a patient with other conditions, we're going to add the code. So adding a code for the coronary artery disease, adding a code for the stage of chronic kidney disease, and probably the least favorite, trying to find ulcer codes. There are so many of them. They're divided into by location and by stage, and whether they are related to pressure wounds or non-pressure wounds. So I am very sympathetic about having the difficulty of trying to find those codes. But if you have a patient with a foot ulcer or other skin ulcer, you do want to use the more specific code and add the additional code. All right, BMI, overweight, and obesity. The only 2 codes in this group that risk adjust are the 2 that are highlighted. So we have a question. Do we use a diabetic with complications code even if we didn't discuss the complication, only the diabetes? Can you tell me what one that might be? Could you type that in? So obviously, if you have a patient with peripheral neuropathy, you're going to be talking about the neuropathy in terms of their symptoms. If they have, let's say, retinopathy, and the patient is being treated for the retinopathy by their ophthalmologist, I would still report diabetes with retinopathy because it's accurate. And you're treating the diabetes. Thank you. Thank you for that. I'm happy that that's the the question. You have a patient with diabetes with retinopathy, and of course you're not treating the retinopathy. The ophthalmologist is. But the fact that you are treating the diabetes affects the complications that that patient has or the manifestations. So yes, I would use that code. It is the more accurate code to use. I would not use, it would not be accurate to use E11.9. Thank you for that. So E66.01 and E66.2, these are the only two codes in the E66 category that have a risk-adjusted factor, and only the clinician can diagnose obesity and assign those codes. So here's the question. Can't the coder just add the BMI code from the record? No. Do I have to document obesity or morbid obesity in my assessment? Yes. It's just an ICD-10 rule, and I like it less than you do. Well, maybe that's not true because I don't have to write it down. I do know we hate to use those codes. Our patient maybe has a printout of the summary, or they go online and look at their diagnoses, and we've put down morbid obesity. So I'm sympathetic to that, but I would say that is the only way you can report that code to the insurance company is by putting it on the encounter. So here's a question from a citation from the coding clinic. And it's a little bit off, but we're going to bring it to us soon. When the BMI is below 40, but morbid obesity is documented by the anesthesiologist, no other documentation, is it appropriate to code morbid obesity? And the answer is code for overweight, obesity, or morbid obesity assigned based on the provider's documentation of these conditions. And the reason that I'm bringing that to you is that patients who have a BMI of 35 or more, who have comorbid conditions, even if the BMI doesn't hit 40, you as the clinician can still document morbid obesity and select E66.01. And this isn't in the ICD-10 guidelines, but we have that document from the coding clinic. And the assumption is that a patient who has a BMI of 35 or greater, who has comorbid condition, it puts them at the same risk of developing other complications. But you need to write those words and select the code in the encounter. So now I'm just going to go through some conditions that risk adjust. None of these are going to surprise you. The codes on the screen, the COPD, chronic bronchitis, and emphysema risk adjust. In the HCC model, asthma doesn't, but it does in some other models. So I would be documenting asthma as specifically as you can for this, using the severity of the asthma for those patients that you're seeing. Here's an example: vascular disease and vascular disease with complications. And you can see that the RAF increases significantly. And I'm going to go back and answer this question in just a minute. The risk score increases significantly for with complications. And here's another time where I'm very sympathetic. There are a lot of these vascular complications codes. They're specific and by location. If we can get those into the problem list so that it's easier for you to use them in a next encounter, that can be helpful. And of course, with a severe exacerbation, a severe complication with ulceration, that significantly raises the score. So can the code, sometimes it can be busy, and we comment on the HPI that the patient has a BMI of 40 and advise the patient to lose weight. Can the coder upgrade and correct that? And Dr. Schultz is replying that the claims generally go direct to the payer without review by our coders. So if you wrote that up in, even if you had coders who were looking through every note, it would be unlikely that they would pull everything like that out of the HPI. It would take them longer to do that, well, maybe not longer, than to see the patient. So really, we put a lot on our clinicians. And we do count on you, if you have noted that up in the HPI, to select morbid obesity in the assessment and the plan. Arrhythmias, codes here that risk adjust. And when there's a little dash behind the code, I'm just showing you that it's not the most specific code. Long-term use of anticoagulants. So if you have a patient and you're ordering who is getting a PTINR, we're going to use long-term use of anticoagulants. If they have a personal history of a pulmonary embolism or thrombosis, we're going to add those codes. But if the patient still has the underlying condition, we're going, like AFib or recurrent DVT, we're going to make sure to add that code as well. The long-term use of anticoagulants does not have a risk-adjusted factor. There are not very many status codes that do. And those codes that start with a Z, they include examinations, vaccinations, and some status codes. And next week, we'll see they include some social determinants of health. Chronic kidney disease, the risk it goes up, of course, as the stage is more severe. N18.9, chronic kidney disease unspecified, doesn't have a risk-adjusted factor. And it's unfortunate, but it doesn't. Now, if I were to look at Crohn's disease, all of the diagnosis codes in Crohn's disease, even the unspecified code, has a risk-adjusted factor. And it makes some sense. I mean, you're seeing a patient who has Crohn's disease. You may not know, is it the small intestine, the large intestine, or both? So even if you choose the unspecified Crohn's disease, it risks adjusts. But how are we ever going to remember, oh, chronic kidney disease unspecified doesn't, but Crohn's disease does? So in general, with a chronic condition, we want to be as specific as possible. Now, there are versions of IMO. We've been, criticizing them a little bit, where there is an indication if you have not reported an HCC condition in the past year. So it's a red circle if you haven't, and it goes to gray if you have. That can give you some indication of what the HCC diagnoses are. But my rule of thumb is, of course, you're going to report it when you're treating it or assessing it or when it affects your treatment. And if it's a chronic long-term condition, we're going to be as specific as we can based on the information that you have. CHF is one that you don't want to miss, because when this occurs with diabetes, COPD, and renal condition, it bumps up the score. It's more than just additive. So at least once a year, you want to make sure that you are reporting congestive heart failure for patients that have this condition. ICD-10 assumes a causal link between hypertension and hypertensive chronic heart disease and chronic kidney disease. So I-10 doesn't risk adjust. When I tell this to clinicians, they're sometimes surprised, and I can see why. So hypertension doesn't have a risk-adjusted factor. But if the patient has hypertension and heart involvement, or hypertension and kidney involvement, those are assumed to be a causal relationship unless the clinician states they are unrelated. Now, the problem, here I give you good news, and now I tell you the problem. The problem is you have to go and find these codes. Once you get them, if you can get them up into the problem list, they're going to be easier to use. And so we can think of this as a process of adding detailed problems to the problem list rather than less general ones if the patient has these conditions. So hypertensive chronic kidney disease, stage 1 through 4, or stage 5, we don't use I-10, we use these specific hypertensive chronic kidney disease codes. We add an additional code for the stage of the chronic kidney disease. Hypertensive heart and chronic kidney disease without heart failure, stage 1 through 4, or stage 5 and end-stage renal disease. If the patient has both of those conditions, they have, ischemic heart disease and chronic kidney disease, then we use these codes, and we add a code for the stage of the chronic kidney disease. And if the patient has heart failure with these other conditions, We have a different set of codes, and we use an additional code to identify the type of heart failure. HIV and AIDS, both B20, human immunodeficiency virus disease, and asymptomatic HIV are in the same category. They carry the same risk score. So a patient with positive HIV status without symptoms, we use Z21. It has a risk-adjusted factor. A patient who has confirmed AIDS or who has had an HIV-related condition, we switch to B20. Dr. Thompson is reminding us that chronic kidney disease code matters now because stage 4 and 5 qualify patients for the COVID-19 vaccine on 3/15 in San Diego. Congestive heart failure also will, but hypertension alone will not. Thank you, Dr. Thompson. One or two other conditions, chronic hepatitis, risks adjusts, codes in B18, chronic viral hepatitis, and codes in K73, chronic persistent hepatitis, not otherwise classified. Dementia with and without complications have the same risk-adjusted score. These includes codes in G30, Alzheimer's, FO3, unspecified dementia, and then FO1, vascular dementia. When we code vascular dementia, we're asked to code the underlying physiological condition as well, or the after effects of cerebrovascular disease. And the after effects codes of CVA, we're going to talk about next week. These dementia codes with and without complications are divided into with and without behavioral disturbances. Other neurological conditions, MS, Parkinson's, and Huntington disease, these carry fairly high risk scores. If you are assessing these, or if these patients' conditions affect an acute or chronic problem that you are treating, you want to make sure to report these once in a calendar year. Remember, the insurance company wipes the slate clean on January 1st, and every year, even though we've told them every year for the last 5 years the patient has MS, we've got to tell them again this year. Doesn't seem reasonable, but it is what happens. If you don't report it, then your risk scores are going to decrease for that patient and for your whole panel of patients. Here are just a list of some cardiovascular conditions and the risk scores that they have. Some of these we've looked at and talked about already. And a citation from the coding clinic about sick sinus syndrome. So how does one code sick sinus syndrome or other significant heart abnormality in the presence of a pacemaker? And the answer, it is appropriate to code the specific condition and the presence of the cardiac device. So we just saw that sick sinus syndrome had a risk score of 0.268, whereas presence of cardiac pacemaker, Z95.0, doesn't have a RAF score. And the thinking about that is that although the pacemaker is controlling the heart rate, it doesn't cure the underlying condition that you are monitoring and assessing. So it is based on the coding clinic, and there are go-to gurus for these kind of nitty-gritty coding questions. We would use both the significant heart abnormality or sick sinus syndrome and Z95.0, presence of a cardiac pacemaker. So we're going to focus on chronic conditions. Although we want all our codes to be specific, we are going to focus on chronic conditions in the problem list that we've moved into the assessment that are long-standing. If they have severity, stage, manifestation, or complications, we're going to use codes that address that. We are going to have the condition, the status of the condition, stable, worsening, progressing, good control, and a treatment plan. And we don't have to write the longest treatment plan in the world, stable, refilling current medications, advised her to keep checking her blood sugars at home, stable, continuing current medications, or renewing medications but decreasing the dose of something. We need the plan is evidence of the assessment and the treatment, of the assessment of the condition on this state of service. When you are treating an acute problem, but the patient's chronic problem affects the treatment today, we're going to add that to the claim form, because that is following the ICD-10 rule, and it follows the rule from Medicare. So we code all documented conditions which coexist at the time of the visit that require or affect patient care. We report codes with manifestations and complications and report each of these annually. So I have come to the end of my remarks, and would be happy to answer any other questions or have other comments that anyone would like to add right now. And you can either unmute yourself and do them verbally, or you can type it into the chat, whichever you prefer. We have recorded this session and the handout, and you should have, I'll be sending the PDF of the PowerPoint as well. And then there is the risk guide, which is part of the handouts that you've received. All right. Oh, goodness.
Sorry, I had a question. Are you able to hear me?
Yes.
Okay, sorry. Couple questions. First of all, if you're seeing a patient after a hospitalization, and let's say it was like COVID with pneumonia, and let's say it's like, I don't know, 3 weeks, they forgot to do the follow-up, we're finally seeing them, they're not having any more symptoms. Do you still, even though they're not presenting the symptoms anymore, and it's not, would you put history of? Because I think I've tried to get an ICD-10 code with like a history of, and it doesn't work. So I just put COVID, like pneumonia secondary to COVID or whatnot. So any hospitalizations, are you able to put the diagnosis of what they were hospitalized for?
So we're going to code conditions that exist today. So if the patient is still having any symptoms from the COVID with pneumonia, then I would continue to use those diagnoses. If they are symptom-free, then we're going to find you a history of diagnosis code. A patient who has had an MI within the last 28 days, we continue to use the MI diagnosis code. A patient who had a stroke, we don't use the stroke diagnosis code anymore because they had that in the hospital. We would use either, if they had any long-term after effects, we would use the long-term after effects. And if they didn't, we would use personal history of. If they go in for an exacerbation of their COPD or their heart failure, and they're coming in for follow-up, of course, you're going to use those codes.
That was actually, you answered my second question. It was the MI question. If you're seeing someone after a month of having an MI. So great on the second question. And then the other one was, when you do have a patient with multiple complications due to diabetes, do you have to list all of those diagnoses? Let's say like they have the chronic kidney disease with like diabetes, and neuropathy with diabetes, and obesity with diabetes, and insulin use with diabetes, and retinopathy with diabetes. Do you have to put all 5 diagnoses, or do you just put one, and then because they have and then just address all of that in your plan, so that, and because it's in the problem list, the coders would know like the HCC or whatnot?
So we're only what's going to happen is anything you choose in the assessment goes to the claim. Anything in the problem list goes nowhere. So for your patient, obesity is going to have its own diagnosis code. How important is it for you to track? So from an HCC perspective, 2 chronic kidney disease conditions are the same HCC score. But what practices tell me is that they want those conditions in the problem list, and that they want they want to track how many of their patients have those complications. So is it important for you to have both of those listed in the problem list, the chronic kidney disease and the neuropathy?
Neuropathy, not nephropathy. So like the
Okay.
numbness and tingling of the extremities.
Yep.
So I'm just wondering if basically if they're on insulin, do you have to, or the eye problems, they're all different parts of a diabetic, right? Like or would it be all in the same HCC?
It's all in the same HCC.
Okay. Okay.
But many groups still want to capture those internally.
Okay, great. Thank you.
And so I'm going to read some of the comments here. The more HCCs you put in, the higher the RAF score. And that is absolutely true. But there are some of those, related conditions. There are some rules within that. But my recommendation is don't worry about those rules. Are they going to count once? Are they going to count twice? If it is relevant and you're assessing it today, then I would put it in the encounter. And absolutely, for the CVA patient, if the patient, we would use history of CVA, and that's an example we'll look at next week, and is why the guidelines say don't code conditions which no longer exist. So the patient isn't having a CVA today. If they have a hemiparesis or another type of long-term after effect, we continue to use that. But if they don't, then we use the history of. If someone has an MI, then we're using the MI diagnosis code for 28 days. And then after that, we use coronary artery disease or whatever their underlying cardiac condition is. For stroke, there's no 28 days rule. When they're come and see you in the office, they're no longer having a stroke, and we don't use that for 28 days. We use personal history of or a long-term after effect.
Betsy, yeah, Jim, just to follow up on that, you were saying that the vascular disease does give you higher risk score. And to me, if they've had a stroke or a heart attack, they've got vascular disease forever. Can I not use that going forward then?
Yes, you can. I'm sorry.
Okay, thank you.
Diagnosis, but you would continue to use the vascular disease.
Yeah, thank you. Okay.
I'm going to go back up and look. I have not planned a session for coding for prenatal patients. If you would tell me what you need for that, you can either put it in the chat or get that to Miss Garcia and she can send that to me. If it's some specific questions, I can record something quick for that, to cover that. And so let me know whether you're thinking about CPT coding for prenatal or if you're thinking about diagnosis coding. And then someone says, I might use the same ICD-10 code in the case of elevated liver function tests and low vitamin D, as I may have different additional patient communication for each of these diagnoses. I'm not sure what that refers to, or what, if there's a specific question, or if you could add to that, that would be really helpful.
I think some people use an abnormal lab value code for those type of things.
Oh, so if there is an underlying condition, so elevated LFTs, if the patient has known liver disease or has cirrhosis, we would want to use the condition code in addition to the elevated lab test codes. If they don't, so you've done a liver function test because you just put the patient on a statin and now they have elevated LFTs, but you have not established a diagnosis, then use the elevated LFTs. But if you've got a diagnosis that relates to the liver, then use that. How do we code for conditions that have resolved? For example, a healed laceration. So if you're doing a follow-up on a patient who had you repaired a laceration a week ago and they come in and they get their stitches out, you can go ahead and use that laceration code. There are some aftercare codes, but you can use that once, but we wouldn't continue to use that healed laceration code, a month later and 2 months later. I've heard primary care folks sometimes mix this up with cancer diagnoses as well. For example, with breast cancer, if the patient had a lumpectomy and radiation with no evidence of disease, but still taking tamoxifen, then we were supposed to code as breast cancer, not history of. Yes, that's one of the things I will address again next week. But if a patient has evidence of a neoplasm or is getting treatment for the neoplasm, we continue to use the cancer code. If they have no more evidence of the condition and they're receiving no treatment, then we still continue to use the breast cancer code. And thank you for adding the comment in and reinforcing that. I appreciate the support. So they're still being actively treated. We use the cancer code. The only other no, I think that's about what I have, unless you have another comment or question. Dr. Schultz, thank you very much for your support and help in the session. And I really do appreciate the help I got from Ms. Garcia and Ms. Clemens prior to today's session. All right. Thank you.
No problem.
Thanks. We'll see you next week.
Bye.
Bye-bye.